So let's get started. Do we get started with 34? Okay. And again, there is, this is all learning. There is nothing called an absolutely right or a wrong answer here. Okay, we all make the effort and we try to do our best. Okay, so this is slide 34. And we'll again alternate, however you guys want to do it.
So I can go first on this one if you'd like.
Okay.
So on this shade biopsy, we have a couple of different areas where there's some action going on. And if we zoom in, there looks like there's some acantholysis within the epidermis. And then if we zoom in even more, we can see some like chorons and grains in there. And because we have a couple of them within this one shade biopsy, I was thinking it was more so Grover's disease than Derrier's.
Yes, yeah, absolutely. This is pretty classic for Grover's tiny papules with the process of acantholysis diskeratosis. Did everybody get this? Any questions? All good? Thumbs up. Okay, good. Let's go to the next one, which is 35.
I can go.
Okay.
So the shave biopsy is demonstrating some parakeratosis in the epidermis. We see not much of a granular layer, it looks like, and some acanthosis. Some tortuous capillaries and leaning towards psoriasis in this case.
Wonderful job. So this is a very common biopsy where, clinically, often this patient probably has psoriasis and he had this lesion where they thought it was like a squamous cell or something. It's not uncommon. And this is what is also referred to sometimes as verruciform psoriasis. And you can see that the areas in there are markedly thick. This area even has a prominent granular cell layer. But overall, you can see that these are the classic features of psoriasis. You can, as you described, the bulbous hyperplasia, the suprapapular thinning, the dilated vessels, the hyperparakeratosis, the neutrophils. So this is pretty, and you can see the nice Monroe's microabscesses with the loss of granular cell layer. So this is a verruciform plaque of psoriasis. Good job. If you get this, then you will never be able to miss psoriasis. So that's good. 36.
I can take it. I thought we had some atrophy in the epidermis and then tons and tons of vessels that we'd call cannonball vessels. So I thought this was stasis.
Yeah, but this is really classic for stasis where you have a thick epidermis, you have fibrosis, and you have this lobulated proliferation of small size thick wall blood vessels with hemorrhage. But this is very classic for stasis. If you didn't have stasis in there, what other entity would look like this? Acroangiodermatitis. So that they could ask you that and it would look the same, right? It's more of a clinical distinction. Good. If I'm turning my face this side, it's because I see you guys on this screen, even though my camera is here. That's why it looks a little weird. Okay, let's go to the next one, which is your 37.
And I can go for this one.
Okay.
So it's looking like we have a lot of the epidermis
Yep.
completely separated from the dermis. So I'm going to say it's a subepidermal.
Oh. Yeah, let me go back to the slide again because it's a little blurry. I don't know why.
Okay. So I would say that this is a epidermal.
A blister, if we can all see it. Is it bloody at your end as well?
It is.
Oh, here it is. Okay, good.
Yes, much better.
Yes.
And I'm seeing a lot of blood, a lot of hemorrhage, and it also is looking like it's very cell rich as well.
Mm-hmm.
And so,
and what are all these cells in there?
It looks like there are a lot of eosinophils.
Yeah.
So this would be bullous pemphigoid.
Yes. So you have a cell-rich subepidermal blister. This is like a little upside down. The epidermis is like fallen off over here. But this again, this kind of a fibrinous degenerated fluid-like stuff in the blister cavity with eosinophils at the base is pretty classic for BP. But this, last time when I was teaching you blistering disease, I did teach you guys that this is the kind of fluid you see in bullous lupus, linear IgA, and in BP within the blister cavity. So this is pretty classic for BP. Any questions? Good. We have the next one, which is 38, and that has an A and a B. Okay. Curious to see what you guys thought about this.
I can take this one. Here, I thought it looked like we had a superficial and a deep infiltrate. And then I thought I saw some mucin as well. And then also noticed maybe some follicular plugging. So I was thinking maybe discoid lupus.
Okay, and tell me what do you think? So you were not bothered about the fact that this looked like a blister, right?
Yes.
Good, because that's just a distractor. That's good. What did you think about the epidermis?
I thought that the basement membrane zone might maybe looked a little bit thickened, and then the epidermis looked thin.
Yes, it's actually really thick basement membrane. Everybody notices that. I do want you to appreciate that. The massive thickening of the basement membrane with the atrophy and the hyperkeratosis and the follicular plugging. But this is a chronic interface, and you are 100% right. This is DLE, where you see a superficial deep lymphocytic infiltrate. And let's see. I'm not a little sure about the mucin. Maybe there is a little bit in here, but I don't want you to mistake this for mucin. This is solar elastosis. Okay. So yeah, so this is going to be a plaque of DLE, and even if you did not recognize there to be mucin, actually you are right. There is some mucin in the slide, but even if that was not present, it would still be DLE because of all this chronic interface change. Good. That was 38A, and now I have a 38B. Do you want to take this one as well?
Yes, I can. For 38B, I also saw some follicular plugging here. The overall picture I saw was a lichenoid inflammation there. Also the thickening of the basement membrane zone. And then I thought I noted some of the like apoptotic cells. So
You mean to say
again,
necrotic cells?
pardon me?
You mean to say necrotic cells?
Necrotic cells.
Yes, yeah, okay. So what do you think this is?
For this, I was also saying discoid lupus.
Yeah, so this is a very common scenario where the clinician actually didn't think that this was DLE. They biopsied it as a shape, thinking this is a tumor. And if you're not thinking right, this on a shape could easily be called as AK, lichenoid AK. And I've seen that a lot of times. And remember, if you heard my lecture, I talk about squamatization of the basal layer in chronic connective tissue diseases. And that's because the DE junction has been insulted so much that it gets a reactive atypia. So it almost looks like an AK. That is called squamatization of epithelium, which is classic for a connective tissue disease. So here you're seeing the very thick basement membrane, the epidermal atrophy, the follicular plugging. And with this degree of inflammation around the vessels and around the hair follicles on the face, you have to think about lupus. And as you said, that they are beautiful plugged follicles. So any of the reactive changes, which is actually which you can see over here, is the thickened basement membrane and squamatization. So this is also a plaque of DLE. Good job. Okay, let's go to the next one, which is 39.
So I can take this one.
Okay.
So I thought this looked like orthokeratosis, some wedge-shaped hypergranulosis, and I thought the reedy looked sort of sawtooth with this lichenoid infiltrate, some like subtle vacuolar changes and like early max justice spaces. So I thought it looked like lichen planus.
So again, very practical lichen planus, very good. nice cells and the ejection.
Dr. Anand, we're
Yeah.
sorry, it's hard to hear you. I don't know if it's your microphone. I don't know if anyone else is getting.
Because I forgot to put my headset on.
We can hear you now. Yeah.
Sorry about that. You should have told me before.
That's okay. We can hear you great now.
Okay. Now better?
Perfect.
I don't
you
even know
sounded
how you guys were hearing me. Were you hearing anything before?
Fine until the lichen planus. That's when we just recently stopped hearing you. So
Okay.
you
perfect.
sounded kind of cool and robotic though, so we were kind of game for it. But
Okay. So you can see here the nice irregular view. Described it very well, Jacob. There's nothing more that I added to it. This is classic for LP. So if anybody had any doubt that they could not recognize this, you should go back and look at it because this is pretty classic for LP. Good. You have the slide number 40.
So for slide 40, we can see a lot of inflammation. The epi is kind of eroded or ulcerated. And when you zoom into the very inflamed parts, you can see the virally infected cells with the 3 M's. So for this one, I went with herpes.
Yes. So low power, honestly, even I was thinking this is like something like pemphigus. Am I wrong? Because the epidermis was denuded and there was an ulcer here, right?
Mm.
But this is what herpes does. Herpes infection is like one of the most annoying slides you can look at because when you look at it, you are confused because there is so much happening. There is going to be lichenoid, perivascular, perifollicular inflammation, ulceration, erosion, acantholysis. So that is what in fact should make you think something that this may be herpes. Okay. And then your best bet is to once you're thinking about that, then you will never miss it because then those cells will be very like they will strike out to you. And you can see that within the blister cavity, you have these cells with the classic viral cytopathic change of the 3 M's. So you have the multinucleation, molding, and the margination of the chromatin. So all of these are virally infected cells. All of these are virally infected cells. And the best place to look for the virally infected cells is in the ulcer, but also look in the follicular epithelium. Sometimes the hepatic cells can just be seen in the hair follicles. In this case, we don't see there, but it's in the superficial sections. Did everybody get that? Okay, good. 41.
I can take this one. So on low power, notice superficial and deep inflammation. So I zoomed in to look at the cell type, and I did see EOs. The epidermis is pretty unremarkable, so I'm thinking arthropod.
Yes. So this is pretty classic. So you can see a superficial deep infiltrate. So the first thing that you want to go up on this and do is to look for the presence and the absence of eos. And you can see that there are numerous eos in the infiltrate in the interstitium. But this would be an arthropodosol where you're just not getting the tick part. But the pattern of acanthosis, the follicular spongiosis, the deep infiltrate with the eos absolutely goes with arthropodosol. So good. We have the next one, which is 42A.
I can take this one.
Okay.
So I could see just some like focal like acantholysis, some dyskeratosis, core ronds and core grains. So I was leaning towards Derriere disease on this one.
Which one, Darius or Grover's?
I was a little bit more towards Derriere's, but I guess you could say Grover's too, because it's pretty isolated papule.
Yeah. Yeah. So why did you favor Darius, just out of curiosity?
I think
I just want to make sure you're thinking right. Why did you favor Darius?
I don't know.
You don't know? Okay.
Give me that.
So,
Yeah.
so everybody agrees this is a cancer of dyskeratosis, right?
Yes.
There's beautiful codons and code grains. These are all the code grains in here, and these are the codons in here. And this is a beautiful codon in here. So this pattern could be Darius or Grover's disease. And if I had to pick up one, so this pattern of acanthoid disc keratosis would be 100% identical to what you would see in Darius and Grover's, okay? And you're 100% right that just based upon this, if I just give you a high power view of this, it would be very difficult to distinguish between the two without the clinical. So honestly, they should, in my opinion, never put both on the same differential. But if they do put that, then I would actually favor Grover's over Darius. The reason being exactly what you said later. Why? Because this is a one tiny small papule, right? And you see that the background epidermis is pretty unaffected. And there is no indication that they're giving over here that there is follicular involvement. So you would favor Grover's. Okay. Or maybe there was a 42B with this. That is why you favored Darius. What is happening in the 42B? And you are
I
right.
think in 42B, it's involving the hair follicle.
Yep.
So.
You kept quiet. You let me go on. Yes, you're right. This is Darius. And that's the reason I forgot there is a 42B, which was representative of the patient. This is the same patient. So you can, and here you can clearly see, and this probably this biopsy has been taken from a site, maybe an intertriginous site where it is, eroded and crusted, and you can see the follicular involvement. So this is Darius disease. You're absolutely right, and for this reason, because there is involvement of clearly the hair follicle. Yes, but if you just had that slide, you would favor Grover's.
Okay.
Okay, great. That was a trick for me. Okay. 43.
I can take this one.
Okay.
So we've got some sponge, and then just mild changes, some para, just mounded para, and it's not really adherent. So I'm between PR and guttate. I lean towards PR.
Okay. Anybody from the Frontier group has any other thoughts? They want to add to it, or everybody agrees?
I thought it was like actually shoulder parakeratosis and more like subderm.
Okay, so one step beyond that. So let me tell you why this is not PR and why you would never pick up PR in this. The degree of hyperkeratosis and the epidermal thickening with the psoriasiform pattern is too much for PR. Okay, so in PR, the epidermis, in real life scenarios, atypical lesions can happen. Okay, and it can be very challenging. But even in atypical scenarios, like the clinician will really have to twist my arm to tell me that this is PR. Like it has to be like a classic clinical scenario because this is not consistent with PR. And the reason is because you start here that the follicular plugging is happening and the epidermis is thick. The conified layer is not just in mounds, but even in between, it is orthohyperkeratotic. And PR should not do that. PR is a very subtle process. If the mounds are there, it's just the mounds. There isn't significant changes involving the epi in the background. So this would not be PR. Now, coming to your thought of sebderm, that is interesting, and I would entertain that. The reason being because there is psoriasiform hyperplasia, and there is a plugged follicle with parafollicular parakeratosis. The answer here is actually PRP. The plugged follicle and the parafollicular parakeratosis and the psoriasiform changes, you would see that in both sebderm and in PRP. But honestly, sebderm is an entity which, first of all, is not really common on your boards. This is something that they do not like to test you on. And then also in sebderm, in this particular scenario, there is a psoriasiform hyperplasia. Sebderm has overlapping features with psoriasis. So when you are seeing this with a bright pink conified layer, which is out of proportion to the thickening of the epidermis, and when you see it in the background, this confluent zones of hyper and parakeratosis, like this is the checkerboard pattern right here. You see that? Those would all be consistent with PRP and not sebderm. Okay, but yes, I do agree. If anything, it is closer to sebderm rather than PR. So I want you guys to understand why this is not PR, because I do see why you would think about it because of these mounts. I'm putting complete section in here. Do you guys get that now?
Yes, thank you.
And you see how on low power, when you look at it, it is psoriasiform, but it is not perfectly. So it is psoriasiform because it has the bulbous VT ridges. But the thickening of the cornified layer is out of proportion to what you would expect. Like for this degree of hyperplasia, you wouldn't expect this thicker cornified layer, but it is. And it's accentuating around the hair follicles, and the granular cell layer is pretty much retained. That is what should make you think about PRP. Okay? Now let's go to the next one, which is 44 and A and B. Okay, this is the 44A, and let's look at the 44B as well quickly. Okay.
I can take this one.
Okay,
So
A.
So in A, you see a subcorneal blister. It is really busy with neutrophils, and then you can kind of zoom in. Yeah, very neutrophilic. And then in B, when you zoom into the subcorneal blister, there were like these nice fluffy.
The B you're saying?
Yeah, in B. So then those, we thought they were like nice fluffy kind of bacterial colonies in there. So we were thinking bullous impetigo.
You are correct. This I would, so, you know, in this particular scenario, so tell me, where do you see the bacterial colonies?
Yeah, in there.
Who else is seeing the bacterial colonies? Like right here?
No.
This is not bacterial colonies. You are right. This is from a patient with bullous impetigo, but I wouldn't want you to right away get there because this could be a scenario for, so start from the top to bottom. How do you approach a subcorneal pustule with neutrophils? What's the first thing?
So, of course, like
First
what is
thing
the cell
is,
type? Rule out infectious process.
yep, so remember that 7 things we talked about. What is the first thing? Bullous tinea, right? Everybody agrees it's not tinea. The second one is bullous impetigo, right? What this clearly isn't, is this not staphylococcal scalded skin syndrome, because it's too inflamed for that, and that's a paucicellular subcorneal blister. Then come to pustular psoriasis, then come to pustular psoriasiform drug eruption, which is AGEP, which it is also not because there are no dermal eosinophils, though if you had this pustule and you had dermal eosinophils, it would be AGEP, okay? And then you would come to things like pemphigus foliaceus, and then you would, or IgA pemphigus, and then lastly, you would come to a diagnosis of exclusion, which is your Sneddon-Wilkinson disease. So what it clearly isn't is bullous tinea, and it is not staphylococcal scalded skin syndrome. The differential in this would be bullous impetigo, we are not seeing the bacteria. Number 2 would be pustular psoriasis, and it's not AGEP. It could still be IgA pemphigus or pemphigus foliaceus, where, remember, pemphigus foliaceus has 2 kinds, right? It's either staphylococcal scalded skin syndrome like, or it could also mimic pemphigus foliaceus, okay? So when I am looking at this slide, these are my, and Sneddon-Wilkinson disease, okay? So these 4 are my differentials. It is bullous impetigo without the bacteria, pustular psoriasis, superficial pemphigus or IgA pemphigus, and then lastly, Sneddon-Wilkinson disease, okay? Then you have to look. So only 4 of these are your differential in this. Then you have to look for what question are they asking you. Are you able to exclude any of those entities based on that? If you're not able to exclude any one of those entities, then they really should have given you just one choice among the 4 of them, because this could be any one of those in the right appropriate context. What they are not likely to give you on this is pemphigus foliaceus, because that I would kind of like less favor it, because here the acantholysis is not prominent, but the neutrophils are prominent. So that leaves you with pustular psoriasis, bullous impetigo, and Sneddon-Wilkinson disease. And in some scenarios, bullous impetigo and pustular psoriasis can look really, really similar, and that's where your histology will really be helpful. Pustular psoriasis does not have to have the background psoriasiform changes. It's a very unique kind of psoriasis where only the subcorneal pustules will predominate. Okay, you are correct. This is from a patient with bullous impetigo, but this is how I want you to think about that slide. Does everybody get that? Is everybody good with that? If they sent you this and they gave you a patient picture, you know, which looks classic for psoriasis, it would be pustular psoriasis. If you have those honey crusts, it would be bullous impetigo. All good with this? Okay. Let's go to the next one. And those are not bacteria in 44B. Let's go to the next one. We have 45.
So here we have a cell-rich subepidermal blister. And in the blister cavity, you can see neutrophils. The blood vessels look normal here. So for this, I was thinking dermatitis herpetiformis.
Yes, so this is a subcorneal blister with neutrophils, and you can see here actually the neutrophils are nicely collecting at the tips of the dermal papillae. So this would be the one that is diagnostic for DH. If you just had this, you could also think about linear IG and bullous lupus and chronic bullous dermatosis of childhood. But this finding right in here, wherein you're seeing this dermal papillae being expanded, and especially over here, neutrophils at the tips of the dermal papillae, this would be dermatitis herpetiformis. Is that good? Okay. Go to the next one, which is 46.
I can take this one.
Okay.
I thought we had a cell pore subepi split, and then that looked like festooning to me, and the vessels were like a little more plump when I was looking at them. And so I thought this was PCT.
Okay. So tell me what you know about cell pore subepidermal blistering diseases. You are the dermatopathologist and you have to form your report. So what will be your differential in this? You don't have any clinical information provided to you, which is most of the times what we deal with.
So PCT, you can have a frictional blister, coma
Not be a
blister.
frictional blister.
Yeah, this doesn't look like one.
Yeah.
So
you are talking about a cell pore subepidermal blister, right?
Mm-hmm.
So 6 diseases.
Okay.
So you said PCT. What's the brother and sister of PCT, which looks exactly like PCT? The 2 brothers and sisters. One is the twin identical. Which one is that?
Am I not thinking of them? Pseudo PCT? Pseudoporphyria.
Pseudoporphyria. Yes. So we've PCT and pseudoporphyria. And then the third
EBA
one
look
is,
like that.
what is that?
EBA.
EBA. So PCT, pseudoporphyria, and EBA look exactly the same on histology. They even have quite a bit overlapping of the clinical because scarring and milia formation, right? On sites prone to trauma.
Yeah.
But EBA can easily be distinguished from PCT and pseudoporphyria based upon the DIF. Because EBA on DIF looks exactly like BP, but PCT and pseudoporphyria will show you the donut vessels. So PCT and pseudoporphyria, you cannot distinguish based on histology or on DIF. You need to do serum and urine porphyrin studies. But EBA, the DIF will distinguish it. Okay, all those 3 diseases are DIF positive. But then we have 3 other diseases which look exactly like this, but they're DIF negative. What are those 3 diseases?
Bullous diabeticorum, is that one of them?
Yeah, bullous diabeticorum. So 4.
2 more.
You can ask for a lifeline. Maybe Jacob can help you.
Lifeline, Jacob.
Um, would it just be the like NSAID? No, NSAID induced would be NSAID induced.
Yeah,
Self-epidermal
NSAID
split.
induced is 5, and the last one is your inherited epidermolysis bullosa group of diseases. So like the simplex, junctional, hemidesmosomal, dystrophic, all those. Okay. The reason I'm making sure that we approach it this way, because they like your concepts have to be clear. Like tomorrow, anytime you come across a cell poor subepidermal, this is a very common scenario for us. We come across this and then the DIF is negative. Then what do? Then you do have a backup. You suggest those other diseases, right? So when you see a cell poor subepidermal, this is how you think about it. The DIF positive, DIF negative. DIF positive, porphyria, pseudoporphyria, EBA. DIF negative, bullous iberocorum, NSAID-induced cell poor subepidermal blisters, and then your inherited EB group of diseases, which should be pretty obvious on the clinical. And don't forget to look up the antigen mapping of your inherited EB group of diseases. That's a very favorite board question. And it's something that I cannot teach you guys because every time I learn about it, I forget. So you guys have to go and you have to pick up any of your derm books and make sure that you know the level of split in all those inherited EB group of diseases, which are all DIF negative. Okay, so this is the 47.
This one looks like an intraepidermal blister, and we can see the split was kind of suprabasilar. And there's some of that tombstoning, so it looks like pemphigus vulgaris.
Why is it not Haley?
That would have more complete acantholysis with the dilapidated brick wall, and pemphigus vulgaris can involve the hair follicle more so.
This to me looks like a dilapidated brick wall. Why is it not Haley? Why is it not Haley? Anybody?
Because of involvement of the hair follicle?
Yep, there's a beautiful involvement of sebaceous gland here. I really want you to recognize that. That is really important. Honestly, if you look at this parts of it does look like Haley. That is incomplete acantholysis right there. Okay, but it is not Haley because of this. Haley will never do that. So this is pemphigus vulgaris. Good. Let's go to the next one.
I can take this. Looks like there's some just compact orthokeratosis, hyperkeratosis, and some irregular acanthosis. And then there's some fibrosis of the dermis too. So I was thinking this was a prurigo nodule.
Yes. And what is the most diagnostic feature of prurigo over here? Because the acanthosis, hyperkeratosis, you can see even in a wart, right? So why wouldn't you pick up a wart?
Maybe the dermal fibrosis.
The dermal fibrosis could be there in a wart as well.
Maybe some like follicular plug-in as well.
It's not the plugging, but it is the hypertrophied follicular and fundibular unit. That is what is called the hairy palm sign. Because the thick epidermis looks like it's the acral skin, right? But it is not. It's because everything is thick, right? But then what are these hair follicles doing? You see the hair follicles? This one here and this one here. Look at how fat they are.
Yeah, definitely.
So that is the diagnostic feature. The other diagnostic feature is, and I want everybody to notice this, you see the vessels, how they are vertically oriented? They are pushed up. The fibers in the vessels are pushed up. This pattern of fibrosis and vascular arrangement is classic for chronic friction. Robin.
I think we lost your audio again, or at least I did. I can't hear you. I don't know if anybody else can.
You cannot. Why this was even happening yesterday when I was teaching. Give it a minute, it will come back. Can you hear me
It's
now?
good now.
It's
It's
better
good
hear
now.
you.
Yeah.
So I don't know why this is happening. I'll have to discuss this with my IT people. But yesterday when I was teaching the MD residents, this is the same thing that was happening. So there is some problem with the internet over here. So if you stop hearing me, let me know because it takes a couple of minutes and then it comes back up again. These are the thickened hair follicles. I really thought yesterday, like those students were like something is wrong with me. They kept on saying they could not hear me, and it's never happened before. But there's obviously some problem. Okay. You have the next one, which is 49.
Yeah, I can take this one.
Okay.
So it looks like a lacy epidermal sign, and sort of multiple levels of separation, subcorneal and subepidermal, with a lot of necrotic keratinocytes, and then an interface dermatitis. And so I was thinking more like a bullous EM or even SJSTN kind of spectrum.
Okay, anybody else wants to take that? This one is a challenging one. Jacob, it's not that easy. And I see what you basically are saying. But it's actually not an interface process, because if it was interface, where would it begin?
Yeah.
At the D junction, right? There is no vacuolar alteration at the D junction. It's actually spongiosis, and it's actually the cells are falling apart. Do you see that?
Yeah.
So it is not an interface process, it's an acantholytic process. And then what are these right here?
Are those dyskeratotic?
Those are not really they are dyskeratotic, but they're also falling apart. Those are core grains.
Yeah.
This is actually Darier's disease.
So Darier's, yeah.
Yes. So it is challenging. And this is what I say, when you get a really good lesion of Darier's, this is how it looks like. There is marked background acanthosis and hyperkeratosis. There is often erosion and crust because of the location of the disease. And this is not unique to you. Even we sometimes will struggle. Are we dealing with a necrotic process, or are you dealing with an acantholytic process? Because what is there in Darier's? It's acantholytic dyskeratosis, right? So then you have to back down and look at the fact. So first of all, like things like EM and Fixstrug, they never produce epidermal acanthosis. If this was the back of the hand, you would understand, right? Like that's thick because of the location. But those interface diseases like EM and Fixstrug, they don't induce epidermal hyperplasia, right? Because they are acute diseases. So the epidermis is thick because of the disease process here. And then the interface change always begins at varying levels at the DE junction. So there is actually this is all acantholysis. Over here, the acantholysis actually looks in a pemphigus-like pattern, right? This just looks acantholytic. But as you move on to the top, you actually see all these cells, and you cannot appreciate the chorons very well because they are mixed in with all this erosion and crust, but they are core grains. So this is Darier's disease. I'm trying to see where I can. Yeah, you see here? See the coron here?
Yeah. Yeah, your eyes sort of get
Distracted by the.
distracted,
But
yeah.
that is okay. So that's why I said that this is a challenging entity. But now you see why it is not what you said.
Yeah, that makes sense, totally.
Always in TE, so this you cannot rely on, right? Like, yes, here it looks like that. I completely 100% agree. It looks like the lacy epidermal sign, but then what about all this? This is not lacy, right? And here, again, because of the things that I said, the cell then does not begin at the DE junction. It's all acantholytic in over here, and the epidermis is very thick, which all go against this being. These are all core grains in here with some chorons. So this is Darier's disease. I know you guys are probably not good with this, not happy with this answer, but life isn't perfect, my
We'll
dear.
live. We'll live.
You will live. Okay. Let's go to the next one. 49 and 50. Oh, okay. This one is a good one.
I can take it.
Okay.
I thought I saw a little bit of vacuolar interface change and maybe some epidermotropism.
Yep.
And so I was leaning toward MF in this case.
You got so close and then you deviated. So you
Oh
said,
no.
you said, did you say MF?
Yeah, mycosis fungoides. That was
Okay.
what I was leaning toward.
So you are almost there. I'm so proud of you because you picked up the right disease, but then you said the opposite thing. You said that you see, didn't you say that you see interface?
I'm sorry, vacuolar.
Vacuolar, okay.
Yeah.
When you say vacuolar,
Yeah.
What do you imply that in your head?
I see some changes at the DJ.
So that when you use the word vacuolar, you're automatically in the interface category. So
Sorry.
don't use the word
Apologies.
vacuolar.
Okay.
You're not thinking about that. But then you also said another thing. Oh, so I get it. You said vacuolar and you said the limbs in the epi.
Correct.
That's why you talked about it. Okay. Vacuolar with limbs in the epi is Pityriasis lichenoides.
Okay.
So if this was MF, so in MF, when you are seeing limbs in the epi, you always have to think to yourself, is there a reason for the limbs in the epi to be there? And if you cannot find the reason, then it is MF. But can you find the reason for the limbs in the epi to be there? You're unnecessarily blaming them. There is a very good reason for them to be there. There is parakeratosis. You have insulted the epidermis. You're actually seeing true cell death. You see the vacuolar with the necrotics? Right? Then why are you blaming the lymphocytes in the epi? There's a good necrotic in here. You just blamed the lymphocytes for no reason. Right?
I guess so.
So this is pathognomic of Pityriasis lichenoides. The the limbs in the epi, and vacuolar alteration, which you only use when we are talking about hydropic degeneration. Vacuolar alteration means the cell death has begun at the DE junction by the vacuoles, which also have the necrotics. And there are no limbs and holes in here. They are true holes because it's vacuolar, but there are no lymphocytes in the holes. You get it?
I do. Thank you.
This pattern of parakeratotic crust with the limbs in the epi and the vacuolar change, and you can see some extravasated blood, is classic for Pityriasis lichenoides. Do you get that? And you see here, there's so many necrotics in here, actually. You see this? MF will not do that. And Pityriasis lichenoides is one disease. That is why it is a mimicker of MF, because it is giving you limbs in the epi. It is the only interface. So all interface diseases should have limbs in the epi, right? Because those will result in the cell death. But for some reason, it's just in Pityriasis lichenoides that the limbs in the epi are prominent. And that is why comes this confusion with the small plaque parapsoriasis, which it isn't, which is an obsolete term. You get it? If you can explain the cause of the limbs in the epi, it's not MF, which you have plenty of cause over here. Is everybody good with that? And I want you to bury this picture in your head because this is diagnostic of Pityriasis lichenoides, like nothing else would do that. Okay, let's go to the next one, which is 51.
I can go for this one.
Okay.
So it looks like we are on acral skin.
Yeah.
And I see a lot of spongiosis throughout the entire thing almost. So I would think this would be more of a pernio or a polymorphic light eruption.
Yeah, so this is pernio, and the acral skin dermal edema with lymphocytic infiltrate equals pernio. Don't get distracted and go up too much on high power, because then I'm totally confused, because now it starts looking like vacuolar change and it looks like a whole mess. You have to stick to low power for pernio. Dermal edema, lymphocytic infiltrate, acral skin, pernio. And yes, it could be PMAD as well, but they want you to pick up pernio.
Okay.
Good. Let's go to the next one, which is 52.
For this one, I just see a solitary papule of dyskeratotic acantholysis. So I call this a warty dyskeratoma.
So this is Grover's disease. So a warty dyskeratoma has to have like a nice endophytic architecture with the verrucous stuff on the top, right? Yes,
Yeah.
this is the pattern of acantholytic dyskeratosis, but this is Grover's disease. Okay, and then Jacob, do you notice those necrotics here again?
Yeah, I can see them. Yeah.
So it's not that they're not there in Dayner's disease, they are there, but in that case, because it was such confluent, it became just prominent.
Yeah.
So in every acantholytic dyskeratotic process, you will see the individual necrotics. It's just that your eyes catch those up because those look more prominent. But you see again here, the process is the D junction is normal. So they are in the upper layers. Okay, the next one is 50.
Dr. Anand, I got a question about that slide.
Yes.
Would the involvement of the hair follicle make you think more diarrheas, or does that not really matter?
So it's actually sparing the hair follicle.
Oh, okay. Even if it's like the area above it, it's not
Above it, yeah.
actually attacking sebaceous glands.
If
Okay.
you cut into it, there would be a hair follicle which would be unaffected by it.
Okay.
Yeah. Okay. Then we have 52 and we have 53.
I can take this one. Here, I thought that there was a lot of hyperkeratosis and some hypergranulosis. And I thought that the stratum spinosum maybe looked a little bit pale.
Yes.
So I was thinking EHK.
Yes, you're right. Taylor, hold on 1 minute. Let us take this book. Hey, Susan. Yeah, can I talk to them? Yes. No, is it that regarding that mycobacterial culture? Yeah, can you just put them? Yeah. Let's give me a minute. Hello. Hi, this is Dr. Anand. Yes. Yes, we had sent that for mycobacterial culture. Yes. Okay. I'm sorry, it is growing the bacteria or no? Okay, so you guys are going to be doing the mycobacterial and the atypical culture, right? The atypical mycobacterial culture. Okay. Oh, so you're just letting me know that it is still pending. Okay. Okay. Thank you so much for letting me know. You can just wait for the final results. Thank you. Thank you. Bye. For someone being very diligent in the hospital, they need to call me for that. Okay. Okay. So you are right. So this is EHK. Now let me ask you why in your boards they're going to put this, they're going to put a what, and they are going to put necrolytic acral erythema. Why wouldn't you pick up the what?
I think with the wart, I would have expected the stratum spinosum to be a little bit thicker and not so pale.
Yeah, pale. It should not be pale, and you shouldn't see those intracytoplasmic peak occlusions, right? Now, why wouldn't you pick up necrolytic migratory or acral erythema, one of those nutritional deficiencies? Why wouldn't you pick up that?
That I'm not sure about.
Anybody? Why wouldn't Taylor pick that up?
I feel like this looks different than ballooning degeneration that we see with that.
Like
Okay.
you'd see the paleness in like the upper third of the epidermis, but you wouldn't see the like
Yes.
pulling away keratinocytes with the eosinophilic inclusions.
Exactly. The two things in the nutritional deficiencies. First of all, the granular cell layer is not there. It's confluent paired cavitation on the top, and it's a psoriasiform process. And most importantly, the process there is necrolysis. So I wouldn't even use the term ballooning degeneration, though I know that all of you guys love to use a fact. To me, ballooning degeneration is what I showed you in ORF, and that classic slide that I showed you, that is ballooning degeneration. It's not really ballooning degeneration, but I understand because everybody uses that, so I'm not going to say no to it. But it is actually necrolysis, but it is of the top layer, so the bottom is down. Here, the entire stratum spinosum, pretty much the entire stratum spinosum is affected. And also you see the pink inclusions, which you wouldn't see in the nutritional deficiency. That's the reason it would not be those. This would be EHK. Good job. Okay, let's go to the next one. This is 54A and a 54B. This one is challenging. This is 54A. Probably the money lies in 54B. So who wants to take this one?
I can try.
Okay, good. I want you to try. It's okay.
Yes, this one I thought saw intraepidermal vesicles with eosinophilic spongiosis. So that kind of put me in the contact versus bug versus drug-induced eczema.
Okay, so how does the epidermis look?
It's kind of irregularly acanthotic.
Yep, it's pretty thick. Okay, good. And then you saw the eos in here. And how do you describe this collection of eos in the epidermis right here?
An abscess, microabscess.
Yeah, it's a microabscess. Exactly. Yeah. It's an eosinophilic microabscess. Now, in how many cases of contact have you actually seen that?
Never.
Exactly. When I see this makes me worried for an immunoblistering disease. Okay, when I see eosinophilic microabscesses, the immunoblistering diseases, you think about immunoblistering diseases. The things that you think about is obviously BP is there, and you also think about pemphigus group of diseases. Okay, because both vulgaris and the foliaceous they can attract eosinophils, and especially to this amount where they are producing microabscesses, actually in the absence of significant spongiosis. You see that? Okay.
Yeah.
So, and the epidermis is very thick, right? And then you had the 54A slide with it. So this is the same patient. In the same patient, what are all these cells?
Like in the dermis, you mean?
Yep.
That's mostly lymphocytes.
Nope.
Or histiocytes?
Nope.
Oh, plasma cells.
Plasma cells. They're a sheet of plasma cells.
Yeah.
Okay? The plasma cells are present here because of the location of the lesion. The plasma cells are not disease oriented here. So you will see plasma cells in patients with these, or you may not see, but they are not important to the slide. They are a distractor. What is diagnostic is what are you seeing in here? This is your epidermis and what is happening in here?
It's like dilated blood vessels.
This is the epi, and do you think
Oh.
what are the cells doing in here?
Falling apart.
They are falling apart. It's acantholysis, right? You see here? You see here on the top, this is the denuded epidermis, but you see at the base, there is suprabasilar acantholysis. So put all these together, a thick epi, eosinophilic microabscesses, plasma cells because of the location, suprabasilar acantholysis. What is that? Thick epi, eosinophilic microabscesses.
Dyshydrotic eczema, right?
No. You wouldn't see acantholysis in dyshydrotic eczema. You wouldn't see plasma cells because plasma cells are not present in the apocytes. Thick epi, eosinophilic microabscesses, suprabasilar acantholysis. I just described to you the triad of pemphigus vegetans.
Oh, okay.
Okay, so going back to this slide, when you see in this particular instance, when you see these thick epi, this kind of epidermal hyperplasia, I want you to take a moment and I want to bury this in your head. When you see this thick epi with these eosinophilic microabscesses, the only thing that your brain should think about is pemphigus vegetans. Okay, this is pretty classic for pemphigus vegetans. Microabscess, thick epi, plasma cells because of the location may not be present. And then you go back into the biopsy and you look for those subtle, there is very subtle acantholysis in here, which, you know, would have been very difficult for me to explain to you guys. You see here how it is splitting off? That is why I put the second part of the slide in there to show you, because there it was really good, but this is pemphigus vegetans.
Can I ask a quick question?
Yes.
I'm just curious about, you mentioned plasma cells, given the location. Is that, does that mean something? Like, is it more intertriginous or how does that work?
So, you know, this is a common thing that mistakes people. Plasma cells are common to locations such as the lip, the genitalia, any intertriginous groin site. They can also be seen on the thigh and sometimes on the legs. So unless and until it has a whole lot of diagnostics on the scalp as well, I don't take them into account. So because, you know, plasma cells in inflammatory dermatology, when you see them, it raises the bells and whistles for syphilis, right? There are some diseases which will have plasma cells like syphilis, like necrobiosis, like lipoidica. But I don't pay much attention to it if it is specific, like they have to be like really out of proportion or something which has to really point me towards a disease when the biopsies are from those sites. Does that answer your question? You will always see them. They will be a distractor. You often see them on the thigh. You often see them on the scalp. You will see them intertriginous sites. You will see them on the, sometimes on the lip. It's sometimes biopsies from the face can have a ton of plasma cells. So I just ignored them. Okay. We have the next one, which is the slide number 55. But that thing which I showed you, the thick epidermis with those microabscesses, that's something that you should remember for pemphigus vegetans. Okay, we have the slide 55. Okay.
Okay, so I can take this one. You have a lot of spongiosis. You can see the decimals all fine. And then you've got the superficial perivascular infiltrate. And then I didn't see any EOs in here. Can you hear me?
Yeah.
Okay, so I thought this was maybe like a acute spongiosis.
Okay, yep. So everybody gets this to be acute spongiotic. I think this is pretty simple. Just notice that paradoxically, sometimes in acute spongiosis, the stratum corneum can remain intact, which is fine. It doesn't have the crust, but this is an acute spongiotic dermatitis. So it would be like a contact, or basically you need to recognize this to be eczema because of the spongiosis and because of the superficial nature of the infiltrate. Okay, good. We have the next one, which is 56. Okay.
So here we have a well-demarcated endophytic lesion. And you can see the cells falling apart even from this power. But if you zoom in, you can see that there's core rons and core grains in the acantholysis.
So this is?
A warty dyskeratoma.
Yes. So this is what you want to see for a warty D. It has to be warty with a very nice endophytic nodule. But you see how warty it is? And because of the warty and the big endophytic nature of this lesion, you know, it is very rarely that it comes off in one piece. It's either cut off into two pieces or you just get the top portion of the acantholysis. This is very common scenario. So that is a warty D. Good. We have the next one, which is 57. Okay.
This one looks like an acute vacuolar pattern. We have a basket weave stratum corneum, some dyskeratotic cells in the epidermis, and then some pigment dropout down in the dermis, and looks like some EOs in there too. Yeah. So I would lean more toward fixed drug eruption because of the dropout in the EOs.
So an acute stratum corneum, necrotics at varying level, that's a very drug-induced factor. Then you see the pigment dropout and you see the EO. So that's fixed drug. Everybody good with that? Good. The next one is 58. Okay. Okay.
So for this one, we have subcorneal pustules on an acral surface, and then a lot of acanthosis. And so I thought this was like palmoplantar pustular psoriasis.
So this would be the differential, right? Like whether this is palmoplantar pustular psoriasis or this is dishydrosis. And sometimes that can be very challenging. So, you know, in general, this is actually dishydrosis. Okay. And the reason I would say that is because of the, you know, generally in palmoplantar pustulosis, when you see this subcorneal pustule, you don't see this much amount of fluid, and it's predominantly pustule, it's neutrophils. Like right in over here, I'm actually not seeing neutrophils. There's an EO, there are some limbs, and there are histiocytes, right? So this is probably more of like dishydrosis or contact mediated. So, and it's secondly impetiginite. These are the bacterial colonies. You can see the nice bacteria in there. So this is impetiginized dishydrosis, but that's an absolutely that whenever you're seeing an acral biopsy, that is something to keep in mind because dishydrosis and pustular psoriasis can be very identical. But just for the reasons I told you, this is dishydrosis. Okay. Good. You have 58 and you have 59. So take this one.
This looks like a chronic interface. It's very atrophic epidermis, lots of pigment dropout too. So I also thought this was a fixed drug.
Okay, yeah, so but fixed drug wouldn't do this, right? This is
Yeah, it wouldn't be as like a
yeah, it
chronic.
would be atrophic, and this is all your
Yeah.
thick basement membrane in here. So
Yeah,
this
so
is a
probably
connective disease.
connective tissue. Yeah.
Yep, yeah, it could be lupus or dermatomyositis, and honestly, it is very difficult to tell the both of them apart. And honestly, I don't even remember what disease this patient had, either lupus or DM. Good. And once you recognize that, you really don't even need to worry about, in my opinion, to look for, because I'm like, maybe mucin is there, mucin is not there, but that's, if I don't see conclusive mucin, I'm still going to call it a connective tissue disease. Okay, good. Then you have the other one, which is 60. Okay.
I can go for this one.
Okay.
It looks like we have a subepidermal blister. And then the next step would be to evaluate cell rich or cell poor, and it's cell rich. The next step after that would be eosinophils or neutrophils. And I thought I saw a lot of eosinophils on here when I was looking. So I was thinking more of like a bullous pemphigoid.
So I often get this kind of a mistake. It's actually not it's mostly neutrophils. It's not eos. So
Okay.
I'll tell you where exactly is the EO. This is an EO in there.
Mm-hmm.
This is a red blood cell. This is a red blood cell. What is looking like an EO is a red blood cell. That's not an EO in there. Other than that, pretty much all the cells are neutrophils. They're not EOs.
Okay. So more of the neutrophil. So it could be like a dermatitis hepatiformis, linear IgA.
Yes, yeah. And because this is more of a linear split, this would be linear IgA or bullous lupus or chronic bullous dermatosis of childhood.
Okay.
Everybody good with that? Okay. The next one is E1. Okay. The nice one. Okay. Curious to think what you guys will say. Any takers for this?
Well, I guess I'll take it. I first thought that it was like ballooning degeneration and ORF. And then I was like, well, maybe that's not ballooning degeneration. Maybe that's just the epidermis becoming necrotic, and it's just like SGS, EM.
Yeah. That's exactly what it is. This is actually from a patient with bullous EM. So you're in the right category. And that is why that is the importance of, first of all, including a little bit of the normal adjacent. So you can see the cell death here, right? You see the interface change here?
Yeah.
Yes. And then the second thing about, so, some people probably thought also about subepidermal blister, right? And the roof of the blister in a subepidermal blister is not necrotic like that. So that's why it's not a subepidermal blister. Second thing, remember in bullous EM, bullous fixed drug, in those diseases, the first step that actually begins is dermal edema. So spongiosis and dermal edema, and I think I did talk about this in my lecture, it can be pretty prominent. Early lesions of EM sometimes can be mistaken for spongiotic process just for that reason, because they have prominent dermal edema. So when you see dermal edema, that actually goes hand in hand with EM and fixed drug. Okay. And then lastly, let's entertain the ballooning reticular degeneration thought. It's not ballooning reticular degeneration just for the reason I said, is because of the interface change. And it is also not the reason it is not ORF is because where is the rest of the epi gone in here? Like in ballooning degeneration, you do see dermal edema, but the prominent feature is the whole epi becoming swollen and necrotic and then getting dead. It's not really like the way it dies is different. So it's not, it doesn't undergo necrosis, but it has fluid and it swells up and leaves behind the reticular lines. So the process is different. But yes, it can also produce you an intact stratum corneum like that. So on low power, it really does look like that. But do you understand the reasoning why this is what?
Yeah, I can see they're not like swollen, and you can kind of see the outline. They're just dead, and
Yes.
then the edges are very helpful to see.
The edges are very, very helpful. And what we are talking about here are not only your both scenarios, but also very real life scenarios, because this is very important. But if you were biopsying this blister on the hand, I bet you hand, foot, and mouth disease or EM were in your differential. And this is how we approach and we talk about those stuff, like why is it not? And that's why it's really, really nice to include what you may think as a normal skin. So you can see here that the cell death has started to happen, which is not what ORF would do, or hand, foot, mouth do. You can see the necrotics in here. Okay, good. Let's go to the next one, which is 62. Okay, this is a very important board slide, instantaneous answer. What are we dealing with here? What disease process are we dealing? Like in the general category.
Yeah, alopecia.
Alopecia, yeah. Scarring or non-scarring?
I'm going to say scarring.
Scarring. So which one is it?
I think it's discoid lupus.
Okay, why do you say discoid lupus?
Maybe just because of the significant amount of inflammation surrounding the hair follicles.
If you say significant inflammation, then what about this poor follicle?
Yeah.
Okay. Okay. So you will not make this mistake again. That's fine.
Okay.
This is diagnostic of LPP. You see this perifollicular mucinous fibrosis. Lupus produces the inflammation, but will never do this. This concept, it almost has a neurofibroma-like stroma around it. And you see how it is being retracted away. This, you see this? Lupus will never do that. Lupus never produces perifollicular fibrosis. It produces perifollicular thickened basement membrane and it produces the inflammation, but it doesn't do this. Okay? And the reason it's not lupus is you see the overlying epi. Everything is normal except for where the follicle is attached, where you see a little bit of perifollicular fibrosis, but the rest of it is all normal. So because of that reasons, it's not lupus. But I just want you to maybe take a screenshot of this or bury this in your head. This actually might be also the screenshot of my Anand Dermpath page somewhere. Somebody did that. It was not me, but it is that diagnostic of LPP. Okay.
What's this finding called again?
What is that?
What was this finding called again? You said mucinous fibrosis?
Perifollicular fibrosis. It's like a concentric perifollicular fibrosis. Like it, to me, to my eyes, it really looks like a neurofibroma like stroma. So this kind of like binucleated, not binucleated, like two shafts. I'm forgetting what is it called? You know what I mean. I'm forgetting the name of the pathology name of it.
Polytrichia or whatever.
Yes, yeah. So and then this, the perifollicular this. Lupus will never do this. And also in inflammation, lupus has much more prominent inflammation around the vessels. And if it is around the follicles, which it often is, it will not be accompanied with this. This is almost like the max dose of space. So that is why this is not lupus, this is LPP. This is a very important slide. Do you guys get that? Like this is diagnostic. The moment I see this, LPP, move on. Okay, good. Let's go to the next one, which is 63. And also the epi was important in there. The epi had no change except at the follicular infundibular unit. This is 63. This, on the other hand, so this actually is also from the scalp. And this patient also has alopecia because you see there is no hair follicles, except that this is not a horizontal section. I don't know whether this patient was biopsied for alopecia or not. Clearly not, because it was a process like that. But if you notice that there are not many hair follicles in this specimen, the hair follicle which is left over here, in contrast to the previous one I showed you, you see it has no peripheral fibrosis, but it has a thick basement membrane. You see that? So you know where I'm heading towards. But and what is this?
Discoid.
This is discoid lupus. You see, there is this is in contrast to the previous slide, where you see the epi. This is normal. The only place it is involved is here, which is the follicular infundibulum. It's normal. And you again compare the same hair follicle. It's just cut off in a different way. Compare this with this. Where this is also the hair follicle, but you see, it has no fibrosis. It has thickened basement membrane and the inflammation. So this is DLE. You see the difference? And the entire epi is affected. It's not just where the hair follicles are coming. The entire thing is affected. And this, by the way, is beautiful, thick basement membrane, and plus there is mucin. Good. You see the 63, this is 64. Okay, we can do this slide. I think I probably should have taken out this slide. What did you guys think about it? If you didn't get it, it is fine, but it's not that big a deal. What did you guys think about it?
We were like all over the place. We couldn't
Yeah.
decide even where we wanted to categorize it. And so
Yeah, even I'm all over the
like,
place.
is it Coxsackie? Like, is
Could
it
very well be, because this does look like ballooning leech. I honestly don't even remember, and I thought to myself I should not, because this you really require the clinical for this. You would think about everything on aqueous skin for this, like, and this doesn't have much of adjacent epi for me to make the diagnosis correctly without the clinical. So we will disregard this slide. I honestly don't remember what the correct answer was. This could very well be a superficially sampled blister of. It actually does fit closest to what you would see in ballooning degeneration. So you're right. So we will disregard that slide. Well, then we have 65. This, on the other hand, would be
Pemphigus foliaceus.
yeah. So this, what would be the differential in here?
Staph scalded skin, pemphigus foliaceus.
Yeah, so either one of them could. So cell poor subepidermal subcorneal blister with superficial acantholysis could be either one of the two. Good. And then lastly, this is the last one, right? Yeah. What is this?
A warty D.
Yeah. So this is a warty D. You see how it's a solitary lesion on the background of what they probably thought was a skin cancer. And you see again how the endophytic nodule is like cut off at the base. That's because it's very endophytic. And it has got beautiful cancer with discavatosis with corons and core grains. So this is warty D. Great job, guys. Was that the last one?
Yes.
Okay, good. Well, you all have a good weekend. Just go through the slides, which you found a little challenging. I think you all did amazing. It's the way you approach it, and for you to understand the subtle nuances, and to know exactly, like, if you have the correct way of forming things in your head, you will never go wrong. So I thought that you guys were doing that, which I really liked. Okay, so next week we are going to, what is it? We did the blistering. I think I'm going to start the granulomatous diseases next week. Or did I teach you guys granulomatous disease already? Okay. Did I
Yeah.
finish the whole granulomatous diseases?
You started it and we didn't do the second part.
So we didn't do the neoplasms?
Correct.
Okay, so I'll finish the neoplastic entities next week, which should not take me more than 15-20 minutes. So we will jump into a study set. You guys have the granulomatous study set?
Yeah, I think we have 2, right?
Yeah.
Gran 1 and Gran 2. So we'll do granulomatous 1.
Okay.
Okay, so we'll do granulomatous 1 and granulomatous neoplasms, and then somebody will have to remind me next week what I told you guys today, because I'll forget. But that's what we're going to do next week. Okay.
Thank you.
Well, have a great weekend.
Awesome.
Thank you so much.
Thank you.
Thank you.
You. Bye.